Buenos días, mis queridos amigos. Gracias por la invitación a hablar con ustedes. Estoy triste porque no pude viajar a México en persona, pero estoy allí con ustedes en espíritu. Muchas gracias. It is a pleasure to virtually be with you all at FedPatMex 2023. I'm just going to take you on a journey through soft tissue pathology. In 30 minutes, we don't have time to cover a topic in depth, but I'm going to show you a handful of interesting cases that I hope that you will like and find interesting. There's not really a unifying theme, except that these are just some interesting cases that I found fascinating. This is the first case. It's a large, deep soft tissue mass in an adult. And you can see there's a lot of variation from low power here. By the way, I'll put all these virtual slides, I'll record this and I'll put it on YouTube and Kiko with links to the virtual slides at some point in the near future, hopefully. So here we can see a cellular nodule in this area, and it's got kind of monotonous spindle cells with some collagen and a little bit of pale substance in the background. Arranged in fascicles. Not a totally specific pattern right here, but I'll tell you what, the monotony, the lack of pleomorphism always makes me think about a translocation tumor, as you all probably know if you follow my online posts and videos. I think the key to the diagnosis here, though, is this area over to the right, where we can see dense sclerotic collagen, and there are all these cracks and spaces. At first, you might wonder if those are vascular spaces. They are not. They're artifactual clefting and cracking around the tumor cells. And what's happening is that the tumor cells, which have a more round, kind of almost a round blue cell appearance here. Let's get that in focus. There, that's a little better. The cells here are not as spindled. They're more round and blue, or even epithelioid, and they're arranged in these cords and chains that dissect through a background of very dense sclerotic collagen. And that is the pattern that is really important for making the diagnosis here. It's cords and chains of round or epithelioid cells in a dense sclerotic collagen background. And so when you recognize that pattern, you can do an immunostain to help prove the diagnosis. And if any of you are thinking of it, you can say it to your neighbor right now and get a bonus point from me. The answer is MUC4, M-U-C-4. MUC4 is the stain that is positive in low-grade fibromyxoid sarcoma. And it's also positive in this entity here, which is called sclerosing epithelioid fibrosarcoma. And so sclerosing epithelioid fibrosarcoma is an interesting and quite rare tumor. It's interesting because it has some degree of overlap or relationship to low-grade fibromyxoid sarcoma, also known as Evans tumor. And you can see that in some cases where you have areas that are bland spindle cells resembling low-grade fibromyxoid sarcoma that then are kind of hybrid and merged together with the more classic sclerosing epithelioid fibrosarcoma pattern. So this case had some spindled areas that did kind of vaguely resemble low-grade fibromyxoid. We saw that cellular nodule earlier. Then you get bland spindle cell areas with very fine, delicate collagen and a little bit of pale kind of edema to myxoid background here. This looks to me quite a bit like low-grade fibromyxoid sarcoma. So I think you could make the argument that this tumor maybe represents one of those hybrid tumors. So low-grade fibromyxoid sarcoma has a tendency to metastasize often many years after diagnosis. Sclerosing epithelioid fibrosarcoma, on the other hand, sometimes is more aggressive and more rapidly aggressive than the low-grade fibromyxoid sarcoma. So there's still some debate over what relationship there is between these two entities, but we do think, or at least I think and believe, and I know some others do as well, that there is some sort of connection between them. So it's a good thing to recognize, because the reason that you want to know about this tumor is this pattern right here is quite interesting, and I would say kind of unusual for soft tissue tumors. And if you had it on a small needle biopsy, you could even be tempted to think about maybe a carcinoma, like say lobular breast carcinoma, infiltrating background collagen or something like that. Obviously, when we have the whole context that this is a large, deep mass, it doesn't make any sense really to be metastatic carcinoma. But if you had a small needle and didn't have radiographic information, that could make it much more challenging. So just recognize this pattern. And, I think the other thing to know is that when they have the areas of infiltrative cord-like growth with sclerotic collagen, that's great. But sometimes you get kind of solid round cell areas or solid kind of almost sheet-like epithelioid cells where there's not as much background collagen. And I had a case like this not long ago, actually, where the round cells didn't really make the classic cords, or they kind of vaguely made cords like you see right here, but without very much collagen in between. And so I struggled with that case, and then I saw that it was mingled with some bland spindle cell areas that vaguely reminded me of low-grade fibromyxoid sarcoma, and then I did MUC4 and it was positive, and that solved the case for me. So these tumors, sclerosing epithelioid fibrosarcoma, they tend to have gene rearrangement of the Ewing's gene, EWSR1, usually fused with CREB3L1. Okay, so the CREB genes are also involved in low-grade fibromyxoid sarcoma, but the majority of low-grade fibromyxoid sarcomas have FUS gene fused with CREB3L2. So there is, again, there's some similarity, but also some difference there. So a subset of these sclerosing epithelioid fibrosarcomas can have that same fusion, the FUS CREB3L2, that you see in low-grade fibromyxoid sarcoma, but most of them actually have EWSR1 rearrangements with CREB3L1. So you can do some more reading about that, but I just want you to recognize this pattern because it's kind of unique and could be confusing if you had never seen it before. And also there's a lot of variability in the pattern and cellularity, which is something that I find true of low-grade fibromyxoid sarcoma as well, that you have variable cellularity and variable background of myxoid to sclerotic throughout the tumor. So there's heterogeneity. Here's another example from a different patient. This is also sclerosing epithelioid fibrosarcoma. Again, that heterogeneity, cellular and then less cellular, sclerotic collagen background, and then other areas with a bit of myxoid background. And that can be kind of a useful clue to the diagnosis. And here we can see more round blue cell appearance. The last example was more epithelioid. Here it's more of an almost small round blue cell appearance, but again with that unique cord-like pattern in a sclerotic collagen background. And just like the previous case, you could confuse this with a variety of other tumors that make cords and chains of tumor cells. So it's good to remember this one and keep it in mind. Sclerosing epithelioid fibrosarcoma. Quite rare. I've only seen a handful of these in over a decade of practicing soft tissue pathology. Now, let's go to a totally different type of case. This is a soft tissue mass from a young child. I think it was an arm mass in a 5-year-old. And obviously, it's a fatty tumor, mostly composed of mature adipocytes, white fat. Just like a lipoma would be in adult. But in young children, lipomas are quite uncommon. They are usually tumors of adulthood. So I'm always cautious before trying to make a diagnosis of lipoma in a young child. The key here to the diagnosis, there are two things. Number one, it's mature fat, but it's arranged in these striking lobules, which are divided by dense fibrous septation. So there's these walled off fibrous bands surrounding each of the nodules of mature fat, okay? So that's one clue. And the second clue is this. There's myxoid change. And in these myxoid areas, you can see there are some bland round to oval to spindle cells, very hypocellular. And then there are mature fat cells of varying size. Some look like more or less regular fat, but some are quite small and almost have like a signet ring-like appearance. And then you can see these delicate capillary-sized vessels. If you have a good imagination, you could see that areas like this could get confused with myxoid liposarcoma. And if you haven't seen a case of myxoid liposarcoma, you can go on my Kiko directory, my mega index for soft tissue tumors, and I've got some examples on there, or you can see videos on my YouTube channel. But the myxoid areas of this tumor can look quite similar to myxoid liposarcoma, okay, because they have bland oval to spindle cells arranged in a myxoid background with some little signet ring-like lipoblasts. So the these are actually lipoblasts here, And the lipoblast, both in myxoid liposarcoma and this tumor, by the way, is a benign tumor, lipoblastoma, something I do not see very often, but it's a good thing to know about. The lipoblasts in this tumor, and also in myxoid liposarcoma, what they're doing is they're resembling the lipoblasts of fetal fat, the fat that is arising during fetogenesis. That immature fat, that's what this benign tumor is doing. And myxoid liposarcoma, which is malignant, it's doing the same thing. It's kind of recapitulating fetal fat development, okay? And so the lipoblast are not the ugly pleomorphic lipoblasts that we see in other types of liposarcoma, like pleomorphic liposarcoma. We don't see those in lipoblastoma or in myxoid liposarcoma. Instead, we see these very bland, little tiny round signet ring cells, or sometimes bivacuolated or multivacuolated cells, but with very benign looking nuclei, okay? So in this case, it's easy to tell because there's so much mature fat. It's easy to tell that this is not a myxoid liposarcoma. But in some cases of lipoblastoma, you can have extensive myxoid change, and those cases can very closely resemble myxoid liposarcoma. So in cases like that, I like to get molecular testing. The reason is that in a young child, liposarcoma is extremely rare. Okay, so it's much more likely to be a lipoblastoma if it's a young child. But the problem is that even though it's rare to get a liposarcoma, in childhood, it's rare to have liposarcoma as a child. But when children develop liposarcoma, the type that they usually get is myxoid liposarcoma. So if I have any doubt, I do molecular testing, and you would find a rearrangement of FUS, F-U-S, fused with DDIT3 is the most common fusion in myxoid liposarcoma. A small subset have an alternate fusion of EWSR1 fused with DDIT3. And then in lipoblastoma, the tumor we're seeing here, what you get is rearrangements or fusions of the gene PLAG1, P-L-A-G-1. That's the same gene that's involved in pleomorphic adenomas of the salivary gland. So molecular is strange like that, and always kind of baffles my mind how you can have the same gene or even sometimes the same exact gene abnormality in totally different and unrelated tumors. So molecular answers some questions for us in anatomic pathology, but also it raises new ones. It doesn't solve everything. So we still, I think, need morphologic findings to partner with the molecular. So that's my view, at least. So this is a nice example of lipoblastoma. And again, some cases will have a lot of myxoid change, others it will be very focal, like here. And some cases can mature completely and just have mature white fat. But the way you'll still know it's a lipoblastoma is that usually it will be a child, and it will also have this nice fibrous septae between each of the lobules of mature fat, okay? But when you get the myxoid change, it's a good thing that I like to teach about because these are pretty uncommon, and if you've not seen one before, you could make a mistake and confuse it with a liposarcoma. So that's a nice example of lipoblastoma, a benign tumor of young children, usually infants, but sometimes a little bit older kids can get it too, but most of them are going to be in children 5 years old or younger. Now let's look at a totally different fatty tumor. This is from a large mass from the retroperitoneum of an adult. So right away we can see it's a hypercellular tumor of atypical spindle cells. In this case, they're kind of arranged in fascicles with some blue myxoid background. So a hypercellular spindle cell tumor, it's got some necrosis, and we're in the retroperitoneum of an adult. The first, second, and third thing on my differential diagnosis is going to be dedifferentiated liposarcoma. High-grade sarcoma in the retroperitoneum of adult, dedifferentiated liposarcoma until proven otherwise, in my opinion. Other people may disagree, but that's the way I think of it, because dedifferentiated liposarcomas are relatively common as sarcomas go in adults in the retroperitoneum, okay? But in this case, we can tell also that the answer is dedifferentiated liposarcoma because we have a high-grade sarcoma plus, right next to it, we have well-differentiated liposarcoma. And there are three main things we look for in well-differentiated liposarcoma. If this were in well-differentiated liposarcoma were in the extremities, we would call it atypical lipomatous tumor. It's the same tumor, we just give it a different name when it's in the extremities because it has a better prognosis there. But the three things I like to see is mature fat, usually with variable size, large, medium, and small size adipocytes, fibrous bands in between, and that's usually this dense, hyalinized sclerotic collagen, and then scattered hyperchromatic atypical cells. And all of those components can vary, and not every case has all of them. But in this case, this case is reading the textbook, so to speak, and it has hyperchromatic atypical cells scattered here that are not as dramatically atypical in this case as in some, with this sclerotic collagen and then the mature fat. So when we have a well-diff liposarcoma with any high-grade sarcoma component, then by definition, that's dedifferentiated liposarcoma. The dedifferentiated component can have a wide range of different morphologic features. A lot of them look like undifferentiated pleomorphic sarcoma, bizarre, atypical spindle cells with no fat, no lipoblast, nothing. But a subset can actually have lipoblasts. In the old days, we said that this was not allowed, but now we recognize that a small subset of dedifferentiated liposarcomas actually do have pleomorphic lipoblasts, and this is called homologous lipogenic differentiation or homologous lipoblastic differentiation if you want to be fancy. But I think it's important to study dedifferentiated liposarcoma because, like I said, they're relatively common among sarcomas, and they can have such dramatic differences in morphology from case to case and even within the same patient's tumor. So I'm going to show you in this case, we've got areas with elongated vessels and atypical cells and a myxoid background, kind of resembling myxofibrosarcoma. We have areas with lipoblasts. We also, let me show you a different slide, same patient, same tumor, but just a different section. In this area, we have a dramatic pleomorphism and bizarre pleomorphic lipoblasts, again with that myxoid background. And this is also a good reminder that any form of liposarcoma can have myxoid background, not just myxoid liposarcoma. You can have myxoid background in a dedifferentiated liposarcoma, in well-differentiated liposarcoma, and in pleomorphic liposarcoma. So the presence of blue myxoid change in a liposarcoma does not prove what type of liposarcoma it is. I've got a whole long video about liposarcomas you can go see on my YouTube channel, and it even has a Spanish translation to the subtitles. You can go click a link down below and see that. So again, just to highlight the wide variation in morphologic appearance from location to location in dedifferentiated liposarcoma. But the real reason I wanted to show you this case, because I've shown and posted many dedifferentiated liposarcomas before in videos and digital slides on Kiko. Oh wait, there's one other pattern. Here's myxoid change, but look how bland. This area kind of looks a little bit like myxoid liposarcoma. Myxoid liposarcoma, though, is very rare in the retroperitoneum. It's usually in the extremities. If I think I see myxoid liposarcoma in the retroperitoneum, it's almost always going to end up actually being a D-diff liposarcoma, or maybe a well-diff with myxoid change, depending on the cellularity and mitotic activity. Or, I've not encountered this in real life, but there are cases of this, a person that has myxoid liposarcoma, say, in their thigh, and then they get a metastasis to the retroperitoneum, because true myxoid liposarcomas can metastasize to weird, unusual locations. So this is just another area. Again, this is the same tumor as the last two slides, just a different area. And this looks very different than the previous two slides I showed you. But now, the real reason I wanted to show you is because this is a fascinating and unusual pattern that I only get to see occasionally. So here we have these swirled areas of spindle cells, again with a little bit of myxoid background. So these, I think, fall into the category of what's called meningothelial whorls, because it kind of resembles the whirling that you can see in a meningioma. And in this case, we're getting whorls of the dedifferentiated liposarcoma, so meningothelial whorl pattern, which is a well-described but relatively uncommon morphologic pattern that can be seen in dedifferentiated, and also sometimes even in well-differentiated liposarcoma, but usually dedifferentiated. And this case was really fascinating to me. There's two reasons I like it. Well, three maybe. one, I like to have the swirly, whirly pattern that you see in meningiomas and in perineuromas. I just like that pattern morphologically for some reason. The other one is that one of the very first papers I participated in as a resident was about dedifferentiated liposarcoma with meningothelial whorls. So this case is near and dear to my heart because of that memory. And then also, look what's in the middle of these meningothelial whorls. Each whorl has a little fiber of skeletal muscle in the middle of it. And I cannot really explain why that's happening. I am not sure if it is because the tumor infiltrated skeletal muscle and then swirled around each fiber, or if the tumor is actually differentiating into mature skeletal muscle fibers. I kind of suspect it's from infiltration and then the whirling developed around the fibers. I have never seen this particular pattern in a dedifferentiated liposarcoma before. I just thought it was fascinating, and I have been saving this up to share at some point in the future, and because it was kind of a special case, and I wanted to share it with all of you. And what's more, look at the background. For some reason, you get all of these kind of bland, multivaculated lipoblasts filling the background space, almost resembling the pattern of brown fat that you see in hibernoma. So what a bizarre, crazy tumor with so many different patterns. So just enjoy all these morphologic patterns for the sake of their interesting nature, but also remember that any sort of tumor you see in the retroperitoneum, always keep dedifferentiated liposarcoma in your differential diagnosis. And if you're having difficulty, you can do testing for MDM2. I prefer using FISH, but some people use immunohistochemistry. Just be careful that you can have false positive staining with immunostains. So you can use molecular testing for MDM2 amplification to help support the diagnosis on a small needle biopsy or in difficult cases. All right. Now, this is the type of case, we're totally changing topics again. This is from the nose of an adult patient, and it was a erythematous papule that the dermatologist thought was either a ruptured cyst or a basal cell carcinoma, if I recall correctly. This is the kind of case that it makes you have bad dreams and nightmares, and I'll show you why. Because there is a ruptured cyst here. Okay, they wanted a ruptured cyst clinically. Microscopically, we see an obvious cyst or a cystic hair follicle, same thing, that has ruptured and spilled its keratin, and then there's a bunch of inflammation around it, right? Well, you know I would not be showing you something like a ruptured cyst unless there was more to the story. And if we look closer in the background inflammatory infiltrate here, we see these kind of enlarged, slightly atypical cells. They're big, they look kind of pleomorphic, but not very cellular. They look kind of like histiocytes, which you would expect to see next to a ruptured cyst, right? But something about them is a little unusual. And there's also a lot of dilated telangiectasias here. So I have to tell you that this was, I don't get credit for this case. My former colleague is the one who first saw this case and recognized these cells in the background. And she did a vascular stain. And let me show you what happened. This is CD31. All of those cells in the background are strongly positive for CD31, and they are actually infiltrative anastomosing vascular channels. And you can see multi-layering and hobnailing of large atypical endothelial cells filling the vascular channels, and the channels anastomosing and interconnecting with one another. So this is actually angiosarcoma, and it just happened to be associated with incidentally, an adjacent ruptured cyst. So this is a reminder to look at the whole slide. Just because you find one diagnosis, don't stop looking, and to always be careful. And if something doesn't seem quite right, look a little closer. And this is a very scary case because it would have been so incredibly easy to overlook this. But thanks to the skilled eyes of my very brilliant colleague, this case was diagnosed and detected. And so this was angiosarcoma with a ruptured cyst in the background. Now, we're going to look at a different case here. Hopefully I can get finished in time. This is a nodule on the foot of an elderly adult man. And you can see it's a multinodular cellular proliferation filling the dermis and probably pushing down into the subcutis and kind of replacing everything. It's multinodular, hypercellular. And when we go closer, we can see that the cells are mostly spindled, maybe spindled, plump spindle cells, or even a bit of epithelioid cells in some areas. And they're kind of arranged in vague streaming fascicles that intersect here. They are atypical, but not dramatically pleomorphic, I would argue. They kind of are somewhat monotonous, but I think they're hyperchromatic, they're enlarged. So to my eye, they seem kind of atypical. As you look around, I don't know where, but there are mitoses in here. They're not numerous, but they're easy to find if you look for them. There's one right here. Here's another right there. So there are relatively abundant mitotic figures. Okay, maybe I haven't looked at this slide carefully. They are kind of numerous. I'm seeing mitoses, quite a few of them now that I look more closely. It's been a while since I looked at this slide in detail. It's from long ago. But I might be struggling, where do I put this? I mean, spindle cell melanoma, spindle cell carcinoma, maybe. You could run the kind of immunostain panel for the kinds of tumors we might see in the face or sun-damaged head and neck of an old adult patient. But this is on the foot. You know, if you did stains, it would be negative for S100, probably negative for keratin, negative for desmin, negative for actin. So then you would left with, well, what is this? Is this atypical fibrosanthoma or pleomorphic dermal sarcoma arising on the foot? That would be very unusual. Well, let me show you another example of this same entity that has kind of similarities with this, but one feature that this case is missing. And then I think the diagnosis will be very apparent to you. It's a nodule, hypercellular, in acral skin, on the foot probably. We go closer, it's made of spindle cells arranged in streaming fascicles. But what do we have here that the other case was lacking? Red blood cells. There are erythrocytes filling slit-like spaces between the spindled tumor cells. And once you see spindled cells in fascicles with extravasated erythrocytes, the first thing that probably comes to your mind is Kaposi sarcoma, because that's what this is. This is nodular stage or tumoral Kaposi sarcoma. And that's what this case is also. But I'll never forget this case because it really stumped me for a long time because it didn't really have much blood. Now, there is a little bit of extravasated red blood cell here. There are some areas with hemorrhage, but not much. For how big this tumor is, there is very minimal hemorrhage. And I think we are so used to thinking about Kaposi sarcoma and Angiosarcoma, for that matter, having a lot of erythrocytes, having a lot of blood in them, because they're vascular tumors. But some cases do not. And it's important to recognize that when we don't see the blood, sometimes our brain just skips right over thinking about vascular tumors. So one lesson that my mentor Mark Edgar taught me was that if you have a neoplasm that you're having difficulty classifying and you're having difficulty getting it to stain for anything, your usual panel is negative, don't forget to do a vascular marker. And I personally like ERG and CD31 as my two favorite vascular markers. CD34 works as well, but you have to be careful because some cases of angiosarcoma, particularly solid nodular ones or epithelioid angiosarcomas, they tend to lose expression of CD34. You have to also be careful in Kaposi sarcoma because Kaposi sarcoma can have diminished expression of CD31. The HHV8 virus actually downregulates that molecule. So ERG is actually my favorite vascular marker because it's very clean and crisp and it's very strong. ERG is ERG. ERG. So you may not have that in your laboratory, but it's a great stain. The one main caution I want to say is that it's a very sensitive marker for vascular endothelial cells, but it is not specific. It can be positive in a variety of other things, including prostate carcinoma, epithelioid sarcoma, and many others. So just remember that ERG is very sensitive, but not specific. So in a hard case, I'll use all three of the vascular markers, ERG, CD31, and CD34. But here we actually don't need any of them. All we need is an HHV8 immunostain. And that's no immunostain is perfect in pathology, but HHV8 is about as close to perfect a stain as we can get. It works very, very well. And so that's, human herpes virus 8, which is the virus that drives Kaposi sarcoma, both in the setting of AIDS and HIV. and also in the setting of a classic type Kaposi, which, if I recall, that's what this case was. It was an elderly adult who did not have any history of HIV or AIDS, but elderly patients can get Kaposi sarcoma caused by HHV8, but it's thought to be due to partially due to the reduced immune system that happens in old age, and also there may be a component of being on the feet because of lymphedema type changes, and that also alters the immune system. So I kind of suspect it's a combination of those. When we see elderly adults with classic type Kaposi sarcoma, the vast majority of them that I've seen in my practice are on the feet or the lower leg. And they often are present alongside lymphedema change, and it's sometimes a debate, I guess, of whether the Kaposi sarcoma caused the lymphedema or vice versa. I have a long video that I made in collaboration with my friend Josette McMichael, aka Global Dermy, on Instagram and Twitter, and she's a wonderful dermatologist, and she presents a lot of clinical information about Kaposi, and then I discuss the path findings, and you can find that on my Kiko and YouTube channels. So just remember that not all vascular tumors have blood, and if in doubt, do some vascular markers. If you're thinking of Kaposi, do an HHV8 stain. And this was a case that I'll always remember because of how tricky it was when the erythrocytes are not present. And then finally, we'll finish up here with a last quick little case. So I showed you this one already. Here's the last case, and this is a papule from the nose that was shaved off by the dermatologist. And I guess I should change the direction so you can see it was kind of, here's the base of the shave, and the polyp came up here. There are some distorted, unusual hair follicle structures with an expanded outer root sheath kind of entrapped in here. And what we see are these big, weird, multinucleated giant cells scattered throughout the dermis, and also some kind of triangular or stellate, spindle to stellate cells, and dense collagen, and dilated vessels, blood vessels that kind of are telangiectasia-like blood vessels. So this is actually just an angiofibroma, also known as a benign fibrous papule. And when you see a weird spindle cell lesion on the nose of an adult, the first, second, and third thing you should think of is probably it's a variation of fibrous papule or angiofibroma. Because angiofibroma / fibrous papule can have a lot of different morphologic findings. Sometimes they have big giant cells like this, or foamy cells, or clear cells, or myxoid change, or scattered pleomorphism, or weird hair follicle structures, or basaloid induction of the epidermis that almost resembles or mimics basal cell carcinoma. You can have a huge range of different unusual morphologies that you can see in these benign angiofibromas of the nose. So this was a really pretty example with giant cells, and some of them almost look Teuton-like, some of them are stellate, some of them have foamy cytoplasm. So I really like fibrous papules, and the kind of key feature that ties them all together is, again, usually they're going to be on the nose, sometimes elsewhere on the face, or rarely elsewhere on the body. And then also, if you ignore the weird-looking cells, you're going to usually find dense collagen bundles, dilated vessels, and plump spindle to stellate, or stellate means star-shaped, but to me, most of the cells that we describe as stellate look more like triangles, to my mind. So in any case, if you ignore the funny-looking multinucleated cells, we have all of the key features here of angiofibroma. It's just we also have weird multinucleated giant cells. So this is just a benign variation of fibrous papule, and the main thing is you don't want to confuse this with atypical fibrosarcoma or other malignant type of tumors, because this is totally benign. All right, well, I hope you enjoyed my cases. I went a little bit over time, but I hope you also enjoy the rest of your meeting, and I look forward to seeing you all in person at a meeting in the future.